During the early stages of pregnancy, roughly 25% of women arrive at the emergency room presenting with vaginal bleeding and pelvic pain. The clinical presentation ranges from mild discomfort to sudden hypovolemic shock. These overlapping symptoms correspond to three distinct pathological pillars: spontaneous abortions, ectopic pregnancy, and trophoblastic disease. Because bleeding and pain point to all three conditions, the external evidence alone cannot isolate the underlying failure. To differentiate them, the clinician uses a triad of diagnostic tools: a detailed bimanual examination, quantitative measurement of β-hCG levels, and transvaginal ultrasound. This differential diagnosis determines whether the medical team can attempt to save a viable pregnancy or must intervene immediately to address a life-threatening emergency. A spontaneous abortion or miscarriage is the automatic termination of a pregnancy before the fetus is viable, clinically defined as occurring before 24 weeks or a weight of 500 grams. These losses result from specific fetal, maternal, or paternal factors. While most are linked to chromosomal anomalies in the embryo, maternal factors like advanced age, hormonal imbalances, or intrauterine adhesions also contribute. When symptoms of an abortion appear, the specific clinical classification hinges on the physical state of the cervix. In a threatened abortion, bleeding and mild pain occur, but the internal cervical os remains closed with a living fetus. In an incomplete abortion, pain intensifies as the internal os dilates. Blood and remnants pass through the open canal, while portions remain trapped. Retained tissue prevents the uterus from contracting, leading to severe hemorrhage. This requires surgical intervention through dilation and curettage to evacuate the remaining tissue. In a missed abortion, fetal death occurs without the body expelling the tissue. Clinical symptoms of pregnancy fade, and β-hCG levels show a measurable drop. The most lethal variation occurs when retained tissue becomes infected, triggering a septic abortion. Driven by anaerobic bacteria, this infection requires massive doses of intravenous antibiotics before surgical evacuation can be attempted. Throughout these scenarios, the internal cervical os serves as the critical anatomical switch. Its status dictates whether management can be conservative or must be surgical. When a patient experiences 3 or more consecutive pregnancy losses, the diagnosis shifts to recurrent miscarriages. While a single loss is often a random chromosomal error, repeated losses are frequently linked to immunological factors or maternal anatomical issues. This anatomical map shows the various failure points across the reproductive system that disrupt pregnancy retention. Investigation focuses on congenital uterine anomalies, chromosomal defects, and cervical incompetence, where the internal os cannot mechanically support a growing fetus. With recurrent miscarriages, the medical focus shifts from acute emergency room management to long-term genetic and immunological mapping. Ectopic pregnancy is the implantation of a fertilized ovum outside the uterine cavity. Though often called extrauterine, implantations can also occur in the cervix or the corneal regions of the uterus. Most often, the ovum stalls and embeds in the fallopian tube wall, which cannot support an embryo. Diagnosis requires differentiating this from acute salpingitis, appendicitis, or a ruptured ovarian cyst, which all present with acute pelvic pain. As the embryo grows, the fallopian tube reaches its structural limit and ruptures, causing massive internal hemorrhage. Treatment involves either surgical intervention, with laparoscopy as the standard, or medical management under specific clinical criteria. Medical management utilizes methotrexate, which inhibits DNA synthesis in the trophoblast cells. This method has a 70 to 80% success rate in properly selected patients. Managing an ectopic pregnancy is a race to prevent maternal death from shock while attempting to preserve the fallopian tube for future fertility. Trophoblastic disease is an anomaly of the trophoblast cells that form the placenta, specifically the syncytiotrophoblast and cytotrophoblast. In a complete hydatidiform mole, an empty ovum lacking maternal DNA is fertilized by a single sperm. That sperm's DNA duplicates, resulting in an entirely paternal 46XX karyotype. In contrast, a partial mole occurs when a normal ovum is fertilized by 2 sperm cells, creating a lethal triploid karyotype. Patients present with vaginal bleeding and a uterus that is significantly larger than expected for the gestational age. the bleeding is often accompanied by the expulsion of grape-like vesicles. On ultrasound, the absence of a fetal sac is replaced by a diffuse echogenic mass known as a snowstorm pattern. Management involves immediate curettage to clear the uterine cavity. Because of the risk of severe bleeding from these vascular tissues, clinicians use potent uterotonic drugs during the procedure. Trophoblastic disease is unique because it can evolve into choriocarcinoma, requiring long-term oncological monitoring after the initial complications are addressed. Vaginal bleeding and pelvic pain are the common symptoms of 3 entirely separate physiological crises. Differentiation requires a clinical decision matrix based on 3 strict metrics. First, the β-hCG trends. Levels fall in a missed abortion, remain stagnant or low in an ectopic pregnancy, and skyrocket in a molar pregnancy. Second, uterine size. It matches gestational age in threatened abortions, measures smaller in incomplete abortions, and is disproportionately large in molar pregnancies. Finally, the status of the internal cervical os distinguishes between a threatened miscarriage and an abortion that is actively progressing. The clinician's responsibility is to save a viable pregnancy when possible, while definitively ruling out conditions that lead to hemorrhage, infection, or malignancy. Successful management of early pregnancy complications relies on executing a rapid, algorithmic clinical deduction under intense pressure.